Welcome to the fourth edition of The Interface Between Medicine and Psychiatry, a continuing education service for psychiatrists, sponsored by SmithKline & French Laboratories. This program presents highlights from the Fifth Annual Conference of the Menninger Foundation. Our program begins with a discussion of recent advances in gerontology by Dr. Lawrence Feigenbaum. Dr. Feigenbaum is Associate Dean and Clinical Professor of Medicine at the University of California at San Francisco School of Medicine and Medical Training Director of Geriatric Service at Mount Zion Hospital and Medical Center.
Why the interest in geriatric medicine now? At the turn of the century, there were 3 million Americans who were over 65. That was 4% of the population. Today, there are about 25 million Americans, but that is 11% of the population. So it is not only an absolute increase in numbers, but a relative increase, and that is continuing. When we're talking about health care now well into the 200 plus billions, and when we know that 30% of that money has to go for the health care of the elderly, it is a significant amount of money, and therefore a lot of people are looking at what is being done, what should be done, and what shouldn't be done. There are so many interesting questions that still have to be answered. What really is the aging process? What regulates it? Is there a biologic clock? Or, accepting that there is, where is it? I think there's an ethical imperative. The elderly are treated poorly, and there is good evidence of that. Not only has the patient, the family, but the physician been schooled to think of, well, what do you expect at your age? There is an assumption that everything is failing and everything is failing at the same rate, and that simply is not true. I think we tend to stereotype elderly and say they're all the same, which they are not. Interestingly enough, physiologically, the elderly differ more from each other than the young. Now, I think that is an interesting thing to keep in mind. When we think of life expectancy, and we think of the rewards of putting your efforts into the treatment of a patient, we tend to think of 72 or 74 or 75 as a life expectancy. So that when we see someone who's 78 or 80, we put them at a minus level at that point. There's not much time left. The 75-year-old male has over 9 years life expectancy. The 75-year-old female has 12 years life expectancy. So that when you're treating someone who's 80 years old and someone says, what are you wasting your time for? I think you might point out that they still have a number of years left, and that it is our responsibility to try to make those as comfortable as possible. I'd like now to turn to what it is clinically that is being done in geriatric medicine that perhaps is different than internal medicine or family practice. I and others refer to these as the 5 I's. These are the things that are not as clearly organ-specific and are things that do fall between the slats and that do concern us. First I, intellectual impairment. Next, incontinence. Next, immobility. Next, instability. And finally, iatrogenic drug reactions. One of the really negative stereotypes in our society, and one of the great fears that the elderly, and for that matter the middle-aged, have, is that they're going to lose their marbles, and that they are going to be a vegetable, and that if you live long enough, it's bound to happen. That is very frightening, and it is something that has been shown to be much more a fear than death itself. We must be sure that our patients and the public generally are aware that this is not a natural aging phenomenon. Incontinence. When the physician goes to the bedside and he sees some blood, he becomes very interested. He has all the hematologic tests he wants to do. He wants to find out the origin of the blood. Comes to the bedside and sees some wet sheets, and he throws the covers back in horror and does not look at this in general as a diagnostic challenge. What is going on? And it is terribly important, because many of the people who are sent to nursing homes are sent there because they have been labeled as incontinent. They may have been incontinent while in the hospital or under certain circumstances, but are not necessarily permanently incontinent, and they being placed in a nursing home at that point may be absolutely the worst thing in the world for the patient. There are various subdivisions of incontinence, and we might briefly touch on those. The first is detrusor instability, a spastic bladder, uninhibited bladder. That is the common variety that is seen in the patient with dementia. That is not just an issue of a loss of frontal lobe function and loss of the inhibitory learned ability to stop urination. What it has to do with is actually a loss at a very different level of inhibitory impulses to the detrusor muscle, so that there are contractions which overcome the sphincter tone and produce incontinence. Probably next most important, if not more important, is spurious incontinence. And that is often the situation where someone is in the hospital, is immobilized. The health professionals are simply not getting to the patient fast enough. The patient is not mobile enough to get to the toilet and wets the bed or themselves, and then is labeled incontinent. The next is the problem of sphincter insufficiency, which is stress incontinence, which can be due to various things, including estrogen deficiency. And the thing that must be looked for, particularly in the institutionalized patient, is the possibility of a fecal impaction. That is a cause of urinary incontinence, and it's a treatable cause. Other causes, of course, relate to medications. Excessive use of diuretics, using diuretics at bedtime, using fast-acting diuretics, so the patient, while sleepy, has to urinate and may become incontinent. The use of anticholinergic drugs, which may result in urinary retention and then overflow. And that leads us to another category of incontinence, which is an entirely different one than the one we've been talking about, the small bladder of detrusor instability. This one is the overflow incontinence, which is a large bladder, and that is seen with obstruction to the outlet, with prostatic hypertrophy, or may be seen with an atonic bladder, with diabetes or tabes. And there are things that can be done about these. Instability is the next I, and that is usually used to refer to falls. And falls in the elderly can have multiple etiologies, and it may often have more to do with weakness, anemia. It may have to do with hazards in the house associated with someone's having visual or hearing loss, rather than, as I say, a strictly neurologic phenomenon. Drop attacks are something we see in elderly and do not see in young. These seem to have something to do with anti-gravity reflexes that suddenly are not working, with a sudden drop, a fall, without loss of consciousness. The patient may remain immobilized for quite some time and be unable to get up, and pressure on the sole of the foot, re-stimulating some of the gravity forces, is the thing that often will just trigger a recovery from that. The importance of falls is not the fall in itself so much as the potential for fractures. The other part of falls is the psychological part. And one of my English geriatrician friends tells me that in a rather informal study that they did, they found that an average of 3 falls resulted in the patient never leaving their home again. Now, obviously, there's great variation in that, but that is a terribly frightening experience for someone elderly with the potential for fracture, and this fear of further falls is one of the major things that can incapacitate people, whether they've had any injury or not. The other part of instability that is usually not talked about under that label is the instability of the homeostatic mechanisms. And that's the reason there are thermoregulatory problems, there are problems in postural hypotension, both of which can be very, very significant in the elderly, in producing hypothermia, the differential diagnosis of which is essentially an almost dead patient. Iatrogenic drugs is the next and probably the most important. The elderly tend to be thought of as daft or deaf, and they are excessively put on neuroleptic drugs. Sleeping pills are excessively used in the elderly, as they are in all age groups, but it is a particular problem in the elderly. Obviously, the anticholinergic drugs can have serious side effects for the elderly. Those things that in the younger people can be tolerated without too much difficulty can be a very serious problem. The person who is interested in geriatrics must do a thorough assessment of the frail elderly person that is heading toward a nursing home. You must feel absolutely certain in your mind and not accept readily, as is often done, that the person, because they are 80 years old and is not thinking properly, is demented. That is a very, very serious mistake. And we are seeing in our assessment service 20 to 30% of the people who have been labeled as demented, ready to go to nursing homes, have turned out to have treatable conditions. Now, drugs. Over and over again, we can be heroes by stopping drugs that the patient doesn't absolutely need. Don't forget non-prescription drugs, alcohol. And alcoholism is not something that nice old folks don't get involved with. And in fact, in retirement communities, there is a very considerable incidence of alcoholism. The presentation of depression often is absolutely indistinguishable from early dementia. The decrease in attention span, the difficulty in concentrating, and they can be exceedingly difficult to distinguish and often impossible. The highest suicide rates in this country are in elderly white males, and by elderly white males I mean 75 and over. Metabolic problems. When an intern calls and says patient so-and-so is not thinking clearly, has become somewhat confused, is alert. I don't mean that they are totally lethargic. The serum sodium must not be forgotten about. Very, very common in the hospital. Interestingly enough, antidiuretic hormone, arginine vasopressin, in elderly people responds more to stress than it does in young people. And with the ADH levels, the serum sodium drops, hyponatremia, signs of forgetfulness and confusion can be mistaken for early dementia. One of the other reasons that this is common in elderly is not only because the ADH tends to go up more, but also because the syndrome of inappropriate ADH hormone excretion is caused by a number of conditions that are commoner in elderly people. Lung tumors, head injuries, skull fractures, strokes, that kind of thing can all produce excessive antidiuretic hormone. Now, hypercalcemia also is something that is likely to be seen in elderly. That's relatively uncommon, but metastatic carcinoma, Paget's disease, common in the elderly, also particularly if the patient's put to rest with a fracture, something of that sort, is very likely to get hypercalcemia, and multiple myeloma. Any of the metabolic failures, renal failure, liver failure, lung failure, can present as a dementia. Dehydration and overhydration. We have seen people in nursing homes who have been assumed to be demented simply because they really could not hear properly, could not see properly, were bumping into people, being irascible, seemingly confused, answering questions in a peculiar way because they didn't hear the questions. The other part of sensory that I should mention that I don't think we pay nearly enough attention to is the stroke patient, where sensory problems in terms of perception, of body image, of spatial orientation can again produce a patient who is acting very peculiar, doing very odd things, and may be considered either demented or psychotic. Of course, the sensory deficit of hospitalization and institutionalization in itself is a very major problem. Nutrition, I think, is very important in the elderly, and we have seen folate deficiencies which have caused a picture of dementia. Thiamine, riboflavin, the various B vitamins. Clearly, nutritional problems are greater in the elderly for a number of reasons. I regret all these generalizations because most elderly are healthy, functioning people. I am talking about the ones that we are more likely to see. They eat less well. They are poorer. They may now be living in areas where they're nervous about going out to shop, or they may have difficulty going out shopping. They may have had loss of smell and taste, so they don't eat as well from that standpoint. They often have dentures, which decreases interest in food. If they're depressed, they're less likely to eat well. Trauma, tumors, and toxins all can produce a clinical picture of dementia, and we've seen a number of subdural hematomas which have been overlooked in elderly. They have falls. They may have forgotten they had falls or not thought to mention it, or nobody's asked them, and this may be the cause. Any infection in an elderly person can present with a confusional state, which once again may be mislabeled as dementia. And that does not require that the patient have fever. Coronaries, acute myocardial infarctions, are silent in about 50% of the elderly, probably greater than 50%. Heart failure, pulmonary embolus, all of them may present simply as confusion. Thought I'd take a couple of minutes to talk about the use of the psychotropic drugs in relationship to the issue of pharmacokinetics. And in case you have trouble in remembering the difference between pharmacokinetics and pharmacodynamics, pharmacokinetics are essentially what does the body do to the drug that's taken in, and the pharmacodynamics really are essentially what does the drug then do to the body. Pharmacokinetic aspects are clear. First of all, absorption. For all practical purposes, despite the fact that many elderly have achlorhydria, absorption is not materially affected in almost any drug that the elderly is apt to take. The important areas are distribution and elimination. And one of the areas that we are less conscious of than we should be probably is the whole issue of volume of distribution. And there is a major change in elderly as compared with young. The fact is that with age there's a decrease in lean body mass, there is a decrease in body water, and there is a relative increase in body fat. So the distribution of the drugs is very different, and those drugs which tend to be stored in lipid areas are going to hang around an awful lot longer. Those that are in the plasma, in water essentially, are more concentrated because of the relative decrease in body water. Because of decreases in serum albumin, protein binding is decreased, so the free portion of the drug hangs around more. And really most important is clearance or elimination. And that is remarkably altered in the liver, both in terms of hepatic enzyme action, which decreases, and another area which we haven't known about an awful lot until relatively recently is the effect of hepatic blood flow. And in the elderly there is evidence that there is less blood flow, and therefore drugs are metabolized less well in the liver. And of course the most well-known is the decrease in renal function, so those drugs that go out via the kidneys hang around longer. One of the common questions asked is, well, with all these problems with these drugs, what do you do about the person who has serious sleep disorders? First of all, it's terribly important that both the patient and the family recognize that with aging, sleep patterns change remarkably. And type 4 sleep practically disappears. There's some decreases in REM. It's a very big subject, how much the subjective data compares with objective data in sleep laboratories is open to some question. And as you all know, many people who complain of essentially getting no sleep, in fact, are getting much more sleep than they recognize. I still believe that Benadryl or parabenzamine, one of the antihistamines, has a role as a hypnotic for elderly. There was a recent article which said, much to my surprise, that there is a far greater risk of delirium with the antihistamines than there are with the hypnotics. Helping to build a coordinated support system is something that physicians have not paid very much attention to in the past. And this, I think, is one of the joys of working in this field. The major goal must be the maintenance of the patient's independence as much as is possible and out in the community. If we can keep people out of nursing homes whenever possible, we have done a great service. Obviously, there are many patients who do require nursing homes, and we can't forget that, but there are an awful lot who are there now, and there are various estimates up to 20% that probably have been inappropriately placed there. Next is an awareness of the need for a really balanced approach to medical intervention. The standard medical school workup for every patient that comes in sometimes can do the patient far more harm than good. On the other hand, we have seen so many other patients who, because of age, have been neglected and have not had the kind of intervention that they should have, that I think the issue is one of a balanced approach. Next is clearly an advocacy for the patient. It's all well and good for us to talk about the care for the elderly, but we mustn't forget that we're always dealing with the individual, and that individual may have very different ideas, desires, wishes, needs than the average, and we have to be ready to respond to those. Another thing the geriatrician must be more aware of is allowing sufficient time for recovery from whatever it is that we're treating. They simply take longer to recover, and one of the major problems we see is the jumping from one therapy to another. The greater awareness of the dangers of bed rest, I think a greater awareness of the dangers of bed rest with decubitus ulcers, as well as contractures, as well as incontinence, as well as phlebothrombosis, as well as pulmonary embolus, as well as pneumonia, on and on. If we can keep people out of bed, we should. And finally, it's a physician who perhaps can accept that death is legitimate and part of the lifespan, and not see it as this terrible admission of failure, which most of us seem to feel by the nature of our actions in prolonging life many times beyond any reasonable norm.
Our program continues in just a moment. First, here's a brief message from Smith, Kline and French Laboratories.
Some things are hard to improve upon, like a Stradivarius and Stelazine, brand of trifluoperazine hydrochloride. In the 26 years since Stelazine was introduced, other antipsychotic agents have become available. None has demonstrated significantly greater overall efficacy or significantly fewer side effects than Stelazine in reducing psychotic target symptoms. Dependable, effective Stelazine, a classic antipsychotic from SKNF, pioneers in psychopharmacology.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, including tardive dyskinesia and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with Stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing Stelazine, please consult the accompanying product information, including additional warnings, precautions, and adverse reactions.
Stelazine, a classic antipsychotic.
Please turn the cassette over for Side 2, a discussion of recent contributions of geriatric psychiatry. Our program continues with Dr. Carl Eisdorfer speaking on recent contributions of geriatric psychiatry. Dr. Eisdorfer is professor of psychiatry and neurosciences at Albert Einstein College of Medicine and president of Montefiore Medical Center.
From infancy on, both biochemically and psychologically, the statistical difference between people increases, so that it is less accurate to talk about the aged than the middle-aged, the adolescent, or the child. And that perhaps is the most important single thing I can give you. that the aged are less alike rather than more alike. The difficulty we face is that we learned a simple, what I call a one-trajectory model of human development. When Freud said older patients were not good patients in analysis, you know what age he was talking about? Oh, just for the record, it was 42. His point was that A, there wasn't enough time, and B, there wasn't enough libidinal energy to make a difference for the rest of one's life. So why bother? And that theme pervaded our knowledge of human personalities. If you look at all the other theories, apart from Ericksonian theory, it's all, as I say, one trajectory. I'm really impressed by the notion that older people haven't learned anything. Wisdom does not seem to be a decremental affair. And while intellectual capacity may go down, wisdom may go up. If it were purely a matter of capacity, then the medical student would be brighter than the professor. Now let's talk about three major problems in the psychiatric areas of aging. I'll start out with dementia, primarily because that's what everybody thinks geriatric psychiatry is all about. Dementia is not a normal characteristic of aging. Dementia is neither the most prevalent, nor, from the layman's point of view, the most frightening characteristic of psychopathology in the aged. Depression is far more prevalent. Senility is a pejorative term meaning two things, neither of which is true. It means if you live long enough, you're going to get squash rot. Baloney. It means that there's nothing we can do with people who have senile disorders. There's no role for the professional. Even more nonsensical. Quite the contrary. It becomes one of the great therapeutic and management challenges. Senile dementia implies that the difference between dementia of early and late onset, there is some considerable doubt that that's the case. Cerebrovascular disorder is a marvelous thing, implying that most of dementia comes from vascular changes in the brain. Not true. Chronic brain syndrome, chronic means slow and insidious, as opposed to acute. The assumption being that if it's chronic, it's not reversible, but if it's acute, it is. That's obviously misguided. There are a number of chronic disorders, particularly drug-related, as you heard, which are entirely reversible if you can make the diagnosis. Now, the important thing is when you talk about dementia, we are not just talking about memory. Memory is, in fact, only one of the elements in a cognitive examination. Attention is more important. Recent learning, which is a summation of memory, attention, and other things. Higher order thinking will typically get displaced, but there's more. Orientation. By the time the patient is disoriented as to time, place, and person, you don't need any advanced degree to make the diagnosis. The patient makes the diagnosis for you by that time, typically, at least within a short frame, and the family clearly has made the diagnosis. Other skills, focal skills, go a lot earlier. The attentional skills may go earlier, short lapses of memory which gets exaggerated. Numerical skills may go very early. Reading and writing may go early. Social skills are very often the first thing to go. Why? Social skills require really a very elaborate and complicated series of interactions. Affect is an invariable problem with patients in dementia. Not necessarily early, but eventually, and often associated with aggressivity or hostility around common household problems like the car keys. Hallucinations or delusions occur but relatively late. Diagnosis of dementia is as traumatic to the patient and the family in terms of its prognosis and its implication for treatment as is a diagnosis of cancer. And it has to be treated with precisely the same concern. Anxiety and paranoia are very important, and they tie in with situational disturbances. Principal form of dementia is the so-called Alzheimer's type of dementia. About half of all of the so-called senile dementias are Alzheimer's disease or a variant thereof. About 15 to 20% have a vascular dementia, and the rest are mixed. Is early onset Alzheimer's disease the same as later onset Alzheimer's disease? We don't know. The one thing we do know is that even at the level of the biochemistry and of the electron microscopy, they're indistinguishable. They seem to differ, however, in terms of their genetics, but we don't know because the genetic studies are still too early. Multi-infarct dementia has a much more fluctuating course and much more emotional lability, and typically a history of vascular disease. We now are no longer sure about the life shortening of Alzheimer's disease. The truth of the matter is, Some patients will show slight deterioration and a gradual decline. Some will decline rapidly and plateau, and some will show that kind of variation. Is there only one kind of what we're now calling Alzheimer's disease? What we are now calling Alzheimer's disease is probably like what we were calling mental retardation. What causes Alzheimer's disease? Number one, we don't know. There are structural changes, and what you see in the neurons now is the presence of an insoluble protein and so-called paired helical filaments, not to be confused with DNA or RNA. These are paired helical filaments, presumably because of an insoluble protein that suddenly appears. Neurotransmitter changes. That's a very interesting history, and that's been the source of one of the major breakthroughs. The precursor and metabolites of acetylcholine are clearly down differentially in the cerebral cortex. For example, they don't change in the spinal cord. So that there are two changes. One, there's a localized change, and two, there's a neurotransmitter change. There are a couple of other changes too. Dopamine goes down, but we don't know what to do with it. That's why we don't know how to make sense of it, except that about half of patients with Parkinsonism get a late onset dementia. Alzheimer's disease? Maybe. Norepinephrine also goes down in late dementia. And now we're seeing a new phenomenon. In a small group of patients with Alzheimer's disease, norepinephrine drops quite significantly. Does this mean it's a subgroup? We don't know. The others, GABA, serotonin, etc., don't really change significantly. The little glimmer here, though, is that there is an immune reaction around somatostatin, which is a neuropeptide. Now, the fact that we're talking about an acetylcholine deficiency has raised a couple of issues. We are now talking very specifically about memory deficit related to the neurotransmitter acetylcholine. Genetic influences. There's a hypothesis that because there have been genetic family relationships reported between Down syndrome and Alzheimer's disease of earlier and mid-onset, that there may be either a familial relationship or, more specifically, a maternal age relationship. Immunologic changes. There appear to be clear immune changes in the course of the disease. Early in the disease, a couple of studies now have indicated that serum immune levels of things like gamma globulin and so on go up, and they seem to drop off rapidly in the disease. At least one group of investigators is convinced that there's a distinctive HLA pattern that distinguishes types of dementia. HLA B7 is reported to occur more frequently in Alzheimer's patients. In those patients with the B7, the attentional deficit is much worse than the memory deficit. I can't leave without talking about slow virus. That's the current hot area. Why? Well, we know there's a neurotransmitter gone, and we know that it's specifically oriented in certain parts of the brain and others, so we're looking for a model. The model that's probably now most current in the literature is the Parkinson's disease model. You have to look at trauma as a basis for so-called later aging changes. That's what we're thinking about in Alzheimer's disease. Could it be a virus? Well, the introduction of slow viruses into the human species is not unknown. The important thing I want to leave you with is that we have now taken a normal condition of aging, i.e. dementia, and graduated it to the form of a disease. Why is that important? Because it's a different attitude. Because if it's normal, then what the hell? You live and you get it. It's a risk of life. If it's a disease, it's worthy of your attention. Please accept that it is a disease, and my prediction is it's going to be more than one disease in the future. Dementia is a behavioral condition. It can be caused by a variety of physiologic and emotional substrates. Some of them are reversible, some of them are not. The disease itself brings on a whole psychological pattern, which can be dealt with. DSM-3 criteria for depression are in fact limited to a smaller group of the elderly than the middle-aged, but the elderly show more individual depressive symptomatology. From a treatment point of view, that's clear. Bipolar depression, lithium works in older people. There is no reason to alter the dose, as far as I know. You certainly have to be a lot more cautious about renal state and the state of the organism, remembering that older people are much more sensitive to the effect of medication. Unipolar depression, same things that work with younger people work with older people. And that includes the range of tricyclics. Again, the secret in geriatric treatment is to try to do with as little medication as is possible. The reaction to loss and reactive depression, first of all, you've got to be very careful. The trigger for these is very often a loss. It is a requirement in a reactive depression you have something to react to, but as often as not, what starts out looking like a reactive depression becomes a very severe endogenous depression, which has to be treated as such. The trick is how not to treat a reaction to loss. The best treatment we have available, and this is true I think across the board at any age, is an attempt to deal with the loss either through a replacement of part of it or a supportive relationship, which basically is a replacement. In neurotic depression, there is every reason to believe that the same psychotherapeutic modalities that work with everybody else will work with the aged. There are a couple of things that seem to work with the aged that don't work with others. For example, I've told people what to do. Go back to work. I almost never would do this with a young patient. More and more I'm starting to do it with younger patients because it works so well with older patients. Very directive kinds of treatment work over short periods. The chronic depressive disorders, I think, are a beautiful example of what happens to people who have multiple losses and where we treat the multiple losses as if they were depression. What I think we do is induce a depression. The psychotherapy with this group of patients has been notoriously not very helpful. Pharmacotherapy is no better. And the contingency therapy seem to be the only ones that work. And unfortunately, you can't always control the contingencies. Here's where a good psychologist who knows about contingency therapy can work with you in helping deal with some of these patients. Existential sadness, very important disorder. Why? Because it's not a disorder. For the person existentially, legitimately sad, there are a variety of things we need to do to be helpful. The worst thing anybody could have done for somebody with existential sadness is to prescribe a medication, whether it's sleep medication, wake medication, uppers, downers, or sidewaysers. Paranoia is the thing that gives professionals working with the aged and long-term care the most difficulty. The first thing you need to know about suspicions and paranoia, the number one thing, is that the patient may be right. Particularly in institutions, theft is very frequent. Some of it conscious, some of it patients accidentally taking what they think is theirs or find attractive because you have demented patients around. So the patient comes in and says that my daughter-in-law is trying to get rid of me, trying to get me out of the house. The patient may be telling the truth. Rearranging of personal possessions. Well, it may be true. Somebody's trying to be helpful in cleaning things up. The suspiciousness may come from a sense of loss, and you don't know how to deal with the loss. And I have a theoretical formulation to give you. I believe that if you're aware of the loss, generally speaking, you'll become depressed. If you experience a loss without being aware of it, same personality, you're much more likely to project and become paranoid. What are the losses in aging? They're the loss of cognition occasionally. They're the loss of hearing, which is 9 times more prevalent in the aged than they are in middle-aged. The loss of physical vigor. A big loss that we didn't think about is the loss of personal protection and security. I mean being afraid to walk in the street and go shopping every day because you're going to get ripped off. The risk factor for paranoia is very high, and in a recent set of studies, it turns out that about 25% of all late-onset paraphrenia and schizophreniform illness was related to hearing deficit. So suspiciousness, can we help? Sure you can. You can subtly try to make it easier for the person to deal with their losses and so on. Transient paranoid reaction. The hallmarks of this are a person who has moved recently, typically has a communication deficit, has usually got auditory hallucinations, believing that people are talking about them. The treatment of choice for these people is very interesting. It's social intervention. And it's fascinating how purely social intervention can break into even a hallucinatory process. Sometimes these people have to move. They may legitimately have reason to fear their environment. Those of you with auditory deficits, how do you know whether people are not whispering about you? How do you know about the subtle loss of discrimination, and so that the words aren't really what they think? Paraphrenia, full-blown hallucinations and delusions. These two, paraphrenia and paranoia with schizophrenia of late onset, are at the nub of the controversy as between European psychiatry and us. Europeans do believe that there is a late onset schizophrenia with most of the Schneiderian A's, and that if you wait, that the paranoia will eventually demonstrate itself as a schizophrenia. Americans still believe paranoia and paraphrenia typically manifests itself in the same kind of paranoid ideation that you would see in a younger patient. What's interesting about this group is that they usually get into deep trouble and almost invariably wind up being institutionalized because they tend to write letters. You know, the manager of that building is running a brothel. The lady next door is having men in all night. Physicians were sending them right into nursing homes. What was interesting about this patient is the kind of therapeutic response that we got from very small amounts of injectable antipsychotic medication. We're talking about a tenth, in this case, of the average injectable dose. We had tried oral medication, and the paranoid patient out and out rejected it because they didn't trust the pharmacist, but they took a shot from the nurse that was on the team. All but one patient cleared up within 3 weeks to a month, and then we used supplementary forms of therapy. In dementia, I think we ought to recognize the following. First of all, when you have a reversible dementia, it's easy to be a miracle worker and develop a cure. We can successfully treat depression. So if you manage to spot the depression, you're going to cure 10% of the patients who wind up at your front door. If you spot the rest of it, you will cure as much as 30% of the dementias that wind up at your front door. Now, what about the patients, though, who have a non-reversible dementia? Well, often as not, you have a secondary diagnosis, and it is entirely possible that you can make significant improvements in the patient's cognitive state and emotional health, and in the family by recognizing and treating that secondary disorder. Referrals for community social services. I think every community, every physician ought to have access to a number where we can plug these patients into a community network of care. The question of institutionalization is a constant and anxiety-provoking one for the family, and should be raised and discussed rather than avoided. Second issue is, I think it's very important that the clinician not impose his or her feelings about institutionalization on the family. Referral for legal and financial counseling may be one of the most important things you can do. These patients never lose their rights technically. We now have all kinds of problems with who's going to pay for the support. You can bankrupt the family with this illness very easily. But much more serious than that is the fact that by not dealing with the legal issues, you may lead to subsequent real problem, because if you don't deal with it early on, when the patient may be able to participate in this, you now throw the family into a real conflict around taking a spouse or a parent to court, and you wind up with sibling hostility and a real family crisis. Counseling or psychotherapy, is it a must in every case? No, but it sure as hell ought to be considered. Environmental modifications can be very helpful. These are little practical things that help, and having social workers pay visits, having psychiatrists pay visits at home can be helpful. Ongoing evaluation of cognitive status. Since dementia is basically a cognitive deficit, and you're dealing with a biopsychosocial system, it very often is the most sensitive element in the system. And it'll tell you if there's something going on medically. You may see it first in an exacerbation of the dementia. It'll tell you if the patient's gotten anxious, depressed, if there's a family crisis. The patient's cognitive status may be a barometer of their microenvironment. Therapeutic family intervention. We have had enormous success in putting our families into self-help groups. And the Alzheimer's Disease and Related Disorders Society is now becoming a national network. Families are desperate for information and often very surprised at what happens, like affective outbursts, aggression, not being recognized by their spouse or parent, and so on. Enormously traumatic. Is there a pharmacotherapy of dementia? And the answer is, well, it depends on what it is you want to treat. The attempt to provide the precursors for acetylcholine have been, in the main, a failure. Physostigmine, the blocker of uptake of the metabolism of acetylcholine, and short-term elements, even in patients with dementia, shown to be a memory enhancer, and we've seen some in normals too, as a matter of fact. Antidepressants work if the patient's depressed. Antipsychotics work if the patient also happens to be psychotic. And now let me tell you a little about antipsychotics. These are the drugs most frequently used in dementia, and they're used for exactly the wrong reason. Most antipsychotics, you know, have a side sedative effect. One of the things that troubles us is that the patient gets agitated, and so we want to sedate the patient. The best way I know of to reduce agitation is to increase exercise. which leads to another form of non-pharmacologic intervention. You got to treat the family and the staff to accept certain behaviors on the part of the patient. Sedative hypnotics, do they have a place? Sure. In cases of agitation that are severe, you may need to use it. You may need to help work with the family and let them use it under certain circumstances. Certainly in a facility you may want to do it. I don't like PRN orders, but you can have PRN and then force a renewal. The treatment approaches that can be used for families and for patients cover the realm. Psychotherapy, family therapy, contingencies, environmental modifications, and cognitive enhancement. So in effect, what it does is to challenge the entire therapeutic spectrum of what we have in psychiatry. Sometimes you need a more depthful approach to psychotherapeutic care. But the important thing first is to recognize that first you're dealing with a person, then you're dealing with a patient, then you're dealing with a geriatric case. That patient with dementia has clear impact on a family that's dealing with a devastating illness. As one of my patient's daughters put it quite succinctly and quite eloquently, the death of the mind may be the worst death imaginable. The question is what we can do to help deal with it.
This concludes the fourth program in our series on the interface between medicine and psychiatry, highlights of the Fifth Annual Vale Conference of the Menninger Foundation. SmithKline & French Laboratory sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was recorded on location in Vail, Colorado, and was produced by SmithKline & French Laboratories and SK&F Co. Now here's a brief message from SK&F.